Welcome back to the Physician's Guide to Doctoring. On this week's episode, we have a guest host, so please be the same respectful audience you are for me and enjoy. In the world of medicine, where every decision can change lives, your peace of mind is crucial. This is where Pattern steps in. Imagine insurance made simple, fast, and personalized, just for you. With Pattern, you're not just getting disability and life insurance, you're insuring your future and protecting your greatest asset, your income. In the past 10 years, Pattern has transformed the way over 20,000 doctors secure their financial well-being. Discover the simplicity of securing your future at patternlife.com or click the link in the description.
Hello, and welcome to another episode of the Physician's Guide to Doctoring. I am your guest host, Dr. Amna Shabbir, and today our guest is Dr. Collin Burks, and we will be talking about everything related to older adults today.
Hey, this is Brad Block, host of the Physician's Guide to Doctoring. This is a personal and professional development podcast for physicians where we have experts on the show that try to teach us everything we should have been learning while we were memorizing Krebs cycle.
Dr. Collin Burks completed a fellowship in geriatric medicine at Duke University and is now a geriatrician and clinician educator. She spends most of her time working in an outpatient geriatric specialty clinic focused on caring for people with dementia and their families. Dr. Burks has particular interest in telemedicine, ageism, and care transitions for patients. Welcome to the show, Dr. Burks. How are you today?
Doing well, Amna. Thanks so much for having me on the show. I'm looking forward to our conversation.
Thank you. So, can you briefly share with the audience what attracted you to geriatrics?
Yeah, great question, Amna. From a very young age, I've always been interested in spending time with older adults. I love the life experiences that older adults often share and just enjoy learning from their wisdom. Within medicine, I was attracted to the focus on providing holistic care to older adults and getting to think about quality of life, which is something we do a lot as geriatricians.
So you talked about holistic care and quality of life there, which a lot of individuals, I think the way we're trained in medicine, don't think about necessarily till we're intentionally taught to think of it on those lines. So if I was to just ask you straight up, what are 3 common mistakes you see other physicians make when they're approaching caring for older adults? And you can pick any setting, inpatient or outpatient, to start with.
Okay, yeah, another good question, Amna. And let me say, there's a lot of good care being provided to patients in our country. There's a lot of challenges within our system, and I am so impressed by all the people out there providing amazing care to our older adults. But there are some differences in caring for older adults, and I think if we're thinking about maybe 3 of those common issues or mistakes that may come up, I would say one of the top ones is ageism. So treating your patients differently because of their age. And that likely is not on purpose, but something that is ingrained in our society and in our healthcare system to discriminate against people due to their age and to either offer or not offer certain procedures, medications, research studies, etc., because of their age. For other physicians out there, I think looking at how you may communicate differently with older adults. What kind of terminology are you using? Are you speaking to the patient directly, or often looking instead at their family member or care partner? Thinking about how you're trying to control their disease. Are you looking at them as a whole person, or are you basing it on their age alone? So there's a lot of ageism out there. Certainly I'm not immune to having ageist practices at times, and it's something we can all work on.
I think you bring up a great point there in terms of just having the ability to step away from our natural thought process, which we all have judgments, we all have biases, just even recognizing it's coming up for you. You are treating this person differently because of their age.
It can be hard to step back and look at yourself that way, but I think we're all better when we can evaluate our practice patterns and how we treat patients and families. Number 2, 3 common mistakes you mentioned I spend most of my time in an outpatient clinic seeing patients for cognitive concerns or dementia diagnoses. One of the common things I see is that patients or family members have actually brought up their concerns about changes in their cognition, well before they get to a specialty clinic like mine or to see a geriatrician or neurologist or another person skilled in evaluating cognition. But maybe 3 years ago, the person was managing their activities of daily living, taking care of their medications, coming to their appointments, and to the eye, it didn't seem like they had any cognitive concerns. But 3 years later, those cognitive complaints have progressed, and potentially we could have done something about it a few years earlier if, physician or provider would have spent a little more time exploring what the patient themselves had noticed.
Kind of just pausing there and reflecting that, is this normal aging or is something different happening? Is this a point of action? Does this require a different intervention? Can we create more support? All those places where we might be missing things if we continue more so also on like point number one, like, oh, they're just older. That's why they're forgetting. They're just older because this is happening or that is happening.
Yeah. And sometimes it's hard to know what is normal aging and what isn't. There are some changes in cognition that happen with age, such as processing speed can decrease with age, and that's normal. But if you are having a hard time figuring out what might be normal and what might be not, that's what geriatricians are here for. Other memory specialists like neurologists, we're here to help.
Great point.
And another common issue or mistake that other physicians might make. We see a lot of focusing on disease control. So focusing on what's that A1C number or what are those blood pressure numbers or, how do we lower a person's LDL? And that might not matter to the patient in front of you. What may matter to them is reducing their pill burden or reducing the number of specialty clinic visits they have. Older adults spend so much time in healthcare settings. That is amazing. And I think really trying to drill down what matters to the person in front of you can help us all provide better care to not just older adults, but everyone.
Yeah. And that is another excellent point, because if we're again going through the usual flow of things, and there's a lot of things that we're doing. If you take, for example, an average primary care practice, there's so much happening there. For some of the audience members, I know I practiced primary care before. I'm surprised there, went for a geriatrics fellowship. And it was really humbling to recognize all the ways in which maybe I could have done things differently, and also recognizing the ways that I can do things differently moving forward. Because at the end of the day, I never asked specifically the question, looked my patient in the eye and asked them this question, like, what matters most to you? The way the healthcare system is set up, somebody can be on that treadmill of a ton of medication, you have polypharmacy happening, all the things that we're doing wrong. You go to the ER, you go to the hospital, you come home, maybe you go to an assisted living or SNF setting in rehab, and then you go back to the ER, and we just keep doing this over and over again. But that is not what matters to that older adult. They have something else that they want to do at that stage of their life.
But Amna, you mentioned, being in primary care, that's really hard. There's so many things that primary care providers and physicians have to manage. And I'm just so impressed by all that you do out there. You're right. I'm simply asking that question, what matters to you in terms of your healthcare priorities can help you make a true difference in that person's life.
Yeah, and kind of like expanding a little bit more, since we touched on primary care and outpatient setting. So if you were to say one thing you wish like people would do differently, I guess like one thing would be asking the patient what matters most to you. But in your expertise, especially you're practicing complex dementia care, you're seeing folks coming in with memory and cognitive issues. What can a busy primary care physician do in their practice to create that moment of pause for caring differently for this older adult?
Yeah, great question. I think in addition to figuring out what matters to the patient and if they have a family or care partner or caregiver around, what matters to that person or to those people, thinking about that person's and asking about that person's day-to-day life can give you a lot of insight into how you may be able to help them. Learning about how a person spends their time and what activities they may or may not need any assistance with can really help you tailor a treatment plan for them. If you want to drill down on something very specifically, I think polypharmacy or taking 5 or more medications is often a burden to patients and families, both for time reasons, financial reasons, logistical reasons, and really stopping to think about analyzing that medication list whenever you see the patient and making sure that each medicine is helping that patient achieve a goal.
It's the end of another busy day. You just saw 20, 30 patients, maybe more. Instead of heading home for dinner with your spouse or playing with your kids, you now begin your night job, charting. Charting is critical for patient care, billing, and medical legal liability, but it steals our focus from our patients, eats away at our time with our families, and keeps us up at night. The burden of always having another chart to complete drains all of us. Freed listens, prepares your notes, and writes patient instructions for you. Charting is done before your patient walks out of the room. Wait, because it gets better. Freed learns your style over time. It's AI, just like a human scribe would, except it will never quit on you. Freed is loved by 3,000 plus clinicians from every specialty. It's HIPAA compliant, takes 30 seconds to learn, and costs only $99 a month. You can try Freed for free right now by going to freed.ai, Freed.ai. Listeners of the Physician's Guide to Doctoring can use the code PGD50 for $50 off the first month.
And what I heard in between all of that was also not be shy of asking your geriatrician friends to help you, because in that busy practice, if you're seeing like 24, 26 patients a day, something as simple as asking about ADLs or IADLs, which, annual visits will sometimes force you to do, and sometimes that information is also not very useful. Actually, most of the time it's not useful. Don't be shy to ask for help. And we know that there are not enough geriatricians out there. So if you are in an environment where it's not as dense of a population in terms of like being replete with resources, can you even ask for virtual help, virtual appointments from geriatricians to have this resource person? Because one thing I loved, Collin, about geriatrics is the multimodal way we're looking at disease pattern. We're looking at helping the older adult. We're bringing in physical therapy, occupational therapy, pharmacy, all these other helping specialties, social work that might not be accessible to somebody in a busy primary care practice. So kind of like not being afraid to ask for help.
Yeah. And, one of the things I love about geriatrics is that we're often working in an interprofessional team, and I get to call on several colleagues to help me figure out a treatment plan and work with patients and families. And I know primary care providers are used to, working with all sorts of different professions and referring patients when necessary to specialists. And none of us can do it alone, right? We have to ask for help. And, I think we as geriatricians are, if we're around, more than happy to see any of your older adults at any time.
Absolutely. So pivoting a little bit from the outpatient setting to the inpatient setting, we talk about delirium quite a bit. We talk about preventing delirium. We talk about, is delirium even a big deal? I know, I cringed a little when I said that. But if there was one thing you wish people would just do differently, you have your older adult, they're in the hospital. What can we do better?
Great question, and probably get a lot of different answers from different people. I think diagnosing, documenting, and talking to patients and families about delirium is one thing that we could all do better. There's the issue of not even diagnosing delirium, and you'll see notes that just say, oh, patient's a little confused this morning, or family says they're acting a little bit off, but there's no exploration of what's off, what's different, why might there be a change. So there's not necessarily that diagnosis of delirium. And then if there's a diagnosis or talked about by the team or nursing staff, it may not be documented in the medical chart. And then I might see the patient in my outpatient clinic 9 months later and never have known that they experienced delirium, which is a risk factor for developing cognitive changes later down the line. And then sometimes it is diagnosed, sometimes it's documented, but then the patient and family don't get any explanation of what delirium is. Delirium, especially if it's a hyperactive delirium in which a person is really inattentive, might start trying to, get out of the hospital bed or try to remove their IV. And it's more hyperactive delirium. It's really scary, both for patients, but also for family members or care partners to observe. And, just taking a few extra minutes to acknowledge that it can be difficult to experience, difficult to observe, can go a long way with families and patients.
That's really important. First validating that it's rough to see your loved one go through that. And then what is that even happening? Like, what is it? Because sometimes people take away, oh, they just suddenly developed dementia, and, kind of like clarifying what is delirium, what is dementia, what is happening. And often just one handout and walking through a handout or a resource that you can share with the patient can be super helpful. I'm going to ask you a question that we as geriatricians get asked quite a bit, which is, will Haldol cure the delirium? Or will the antipsychotic? Because that's how it's ordered, right? It's ordered for delirium, and then before you know it, the patient's gotten it. What are your thoughts on antipsychotics, older adults, and all the things?
I wish we had that cure for delirium, Amna. Maybe someday. The best cure is prevention of delirium. Unfortunately, antipsychotics do not shorten the period of delirium or cure it, and can have their own host of possible side effects, including increasing risk of urinary retention, which we see in the hospital already, increasing risk of falls, increasing risk of cognitive problems down the line, movement issues. So certainly there are times and places where we have to use medications such as antipsychotics to keep patients safe. Generally, the less the better.
You mentioned that so elegantly, the less the better, and kind of looking at preventing, looking at underlying causes. I will give a shout out to a special resource that's out there for any physician in practice. You can look at geriguides.com, and it has a really nice flow chart in terms of managing delirium, inpatient management of delirium. There is a specific chart on antipsychotics, and so it's geriguides.com, and we'll put the link in where you'll see the show notes. Dr. Burks, we're not treating delirium with that. We're explaining it to the patient's family is important. Why is delirium such a big deal? So you mentioned earlier that there is, the risk of cognitive decline can happen. So knowing this, documenting this is important. Would you say like delirium is actually a medical emergency?
Yeah, delirium is an emergency. Something is wrong. There's an infection, there's pain, there's an altered sleep-wake cycle, there's a medication problem. Something is wrong to cause changes in the brain that manifest in this inattention, disorganized thinking, fluctuations. So it is an emergency. We have to evaluate what is causing this person to experience delirium and what are those underlying precipitating factors that we can address.
Absolutely. And when would be a good time to call a geriatrician inpatient?
Yeah, great question. And, I will say it works differently at different institutions. So in some places, geriatricians provide primary care and have, a service in the hospital where they manage their own patients. In other places, geriatricians act as specialty consultants, will be called to evaluate patients in the hospital. Like you said, delirium is one of our major consult reasons will also can help begin the process of teasing out, is this delirium, or maybe the family's starting to report some subacute or chronic cognitive changes, and what should be done about that in the hospital and what follow-up might they need outside of the hospital. So delirium or cognitive changes are a reason to consult us, and especially if the delirium, like I said, maybe manifests as hyperactive delirium, then if needed, we can help with medication management. Apart from delirium and cognitive changes, I really enjoy consults about polypharmacy. So patient that comes in and maybe is on Benadryl, some opioids, some antihistamines, gabapentin, 3 blood pressure medications, and figuring out how we can optimize their medication regimen, both in the hospital and then for whatever transition they're going to make out of the hospital, is something that we can certainly hopefully be helpful with in the hospital. Advanced care planning, or again, thinking about care transitions. Is this person in the hospital? Do they need to go to a rehab, or are we thinking about transitioning to a long-term care, like an assisted living or nursing facility for long-term care? We can help out with those assessments and conversations with patients and families.
That is a very comprehensive list. Thank you for sharing that. I think I just really wanted to bring to everyone's attention all the ways that calling your geriatrics colleagues can and really empower the team, because at the end of the day, we're all on the same team, and the goal should be helping this older adult, not putting them in a box and labeling them, and not recognizing our biases and asking them what matters most to them. And if we allow different members on the team to come together and help the family and help the older adult kind of honor what their wishes and their goals are, that is the best way we can provide care, because inpatient settings in specific are notorious for being not friendly for old adults. And if you can ask that person, ask that human, what are their wishes, I think it's incredible. And absolutely polypharmacy. I think the conversation regarding delirium and older adult care is always incomplete if we don't mention diphenhydramine and what it does to older adults. So please, if I could have a take home, that would be that. Please really reassess, why would this older adult need Benadryl/diphenhydramine in this situation? So as we kind of wrap up today, Dr. Burks, what are any take-home points that you want our listeners to have as they think of caring for older adults?
Yeah, thanks, Amna. I think we've gotten to touch on a few interesting points today, and you've summarized a little bit. Again, number one, kind of examine your own biases and note whether there may be ageism playing into the care you provide to patients, is one thing that we could all be doing. Number two, like you mentioned, trying to drill down to what matters to that patient can help you tailor a plan and work with patient and potentially family on something that is actually going to help them. And then I think number three, like I said, and at least in my clinic, I'm always happy to see your patients. And one way to remember what geriatricians focus on is with our framework of the 5 M's. For those that haven't heard it, how one way that we advertise our expertise is by telling people that we focus on 5 words that start with M. So that's mentation, mobility, medications, multi-complexity, and matters, or what matters most. If your patients are dealing with any of those 5 M's or multiple, super happy to see them and work with you to take care of our older adults.
Thank you for your time, Dr. Burks.
Thanks, Amna. Enjoyed the conversation.
Doctors dedicate our lives to caring for others. It's time someone took care of us. Visit patternlife.com to simplify your path to peace of mind. Patternlife.com, simplifying your insurance journey. Thanks for listening. I have a favor to ask. You listened to the episode until the end, which means you either fell asleep or you really liked the episode. So please share it, or like it, or comment on a social media post, or write us a 5-star review. Something. It would really help me out. And maybe what you learned from this episode can help someone else too. The views expressed in this episode are those of the interviewer and interviewee and don't represent the views of their employer or even their significant other. Even though the magic of podcasting make it sound like I'm talking directly to you. This is not a doctor-patient relationship, and this is not medical advice, or financial advice, or really any advice. Thank us again for listening to The Physician's Guide to Doctoring.